Hi, I am Dr. Sharjeel, and today I'll present two patients of one of the most important and common ocular condition that lot of students were asking me to teach and make a video, and I was waiting for the right moment for the actual patients to come to me so that I can prepare a lecture and show you findings on the actual patients. Now, as you can see, the disease is of the cornea, and you can see a dendritic pattern on the slit lamp examination of this cornea, and that is covering superiorly. The ulcer is superiorly, and it is coming downwards from the superior cornea into the center of the pupil, and you can see the branching pattern of that disease. So both patients were male, and now the first patient which I am showing you, he was a 50 years old, and he presented with decrease of vision, watering, photophobia, mild discomfort. Patient used steroid antibiotic combination drops before coming to me, and stated that his condition exacerbated instead of improvement. When I examined, the patient had dendritic stellate shaped ulcer covering the pupil and was involving superior cornea. So I checked the corneal sensitivity. There was corneal anesthesia, and then I stained the cornea with fluorescein, and after the fluorescein staining you can see that the branching pattern of the ulcer is highlighted, and normally the bed is stained by fluorescein, and the epithelial dendrites, the superficial, the terminal buds, they are better stained with rose bengal. So here we have stained the ulcer with fluorescein. So whenever you find a corneal pathology, check corneal sensations with corneal bud, stain it with fluorescein, and confirm its extent and shape, and that will give you clue towards the diagnosis. Ask about the history of trauma. I asked about the history of trauma and previous medications. He had used topical steroids, and the dendritic herpetic ulcer worsened and progressed to geographical or amoeboid configuration. So I diagnosed the patient with herpes simplex, epithelial dendritic keratitis, that has now become a geographic one. Branches of the ulcer have characteristic terminal buds. You should ask in the history of genital and oral ulcers, eyelid lesions, immunity status, whether immunocompromised or immunocompetent, history of previous red eye episodes, stress, exposure to stress, ultraviolet rays, heat, weakness, and if female, menstruation, and trigeminal nerve manipulation. Both herpes 1 and 2 can cause this disease, but mostly HSV1 causes this infection. And now I would like to show you the second patient. It was a younger patient of 20 years old, and he also presented with photophobia, discomfort, and incidentally he also used steroids and topical steroids, and the condition worsened instead of improvement. So when I was checking him on the slit lamp, there was a peripheral ulcer. It looked like Murans or peripheral ulcerative keratitis, but as there was no pain, there were no joints involvements, and when I stained the lesion, it was serpentine looking ulcer corneal sensation was decreased. So I also diagnosed him as a case of geographic dendritic herpes simplex keratitis. So the ulcer was also amoeboid configuration. So what are the differential diagnoses of the dendritic? Well, the dendritic ulcer, the true differential is herpes zoster keratitis, and the differentiation is that herpes zoster is usually at the periphery, herpes simplex is at the center, but that's not 100% sure, because here you can see it was at the periphery, and the terminal buds or bulbs, they are present in herpes simplex, whereas there are tapering ends of the herpes zoster. And most of the other conditions which comes in the differential diagnosis, they are actually making pseudodendrites. So what comes? Healing corneal abrasion, acanthamoeba keratitis, adenoviral keratitis, tyrosinemia type 2, toxic keratopathy secondary to topical medications, corneal graft rejection, epithelial rejection, especially staphylococcal marginal keratitis. They all make pseudodendrites, not the actual dendrites. So now come to the management. So HSV epithelial, you can see here the serpentine pattern stained. So HSV epithelial keratitis usually resolves spontaneously within 2 to 3 weeks, but may cause complications associated with it. And antiviral, topical and systemic medications can not only shorten the course of the disease, but also decrease the chances of long-term complications and recurrences of the viral infection. So mainstay of the treatment is topical antiviral ointment acyclovir 3% 5 times a day for 2 weeks. 99% of the ulcers will heal within 2 weeks. If topical antivirals are used for more than 3 weeks, chances of treatment toxicity increases in the form of punctate keratopathy, follicular conjunctivitis. Now, epithelial debridement can also be done in resistant cases to reduce the viral load and protect the healthy nearby epithelium, as well as to decrease the chances of underlying stromal keratitis. Patient is usually followed up after a week, and if no response to the treatment occurs after 1 week of the topical therapy, possibility of the resistance to antiviral therapy, antiviral toxicity, poor compliance, or alternate diagnosis should be considered. Oral antivirals 400 mg acyclovir 5 times a day for 10 days is indicated as an alternative to the topical, or in combination with topical in children, immunocompromised, and patients with marked ocular surface disease, and when topical therapy is having resistance or not tolerated by the patient. Sometimes topical antibiotics 3 times a day are also given for the bacterial superinfection. Slow healing occurs in resistant viral strains and may cause visually significant stromal corneal opacity. Keratoplasty, lamellar or penetrating, may be performed once the disease is quiescent. Chances of rejection are high in post-viral corneal opacities, and if rejection occurs, Boston keratoprosthesis is a viable option. Apart from the visually significant corneal opacity, other complications are recurrent corneal erosions, metaherpetic ulcers, neurotrophic geographic ulcers, bullous keratopathy, secondary lipid keratopathy, and irregular astigmatism. Prognosis is good in most of the cases, but steroids should be avoided. Most of the misdiagnosed and malhandled cases, like those with geographic ulcers, end up with above mentioned complications. So overall, prognosis is good and clinical diagnosis should be accurate, and you can prevent the patient from long-term complications. Thank you very much.